Hello everyone. Today I will discuss competency PH 5.3, that is motivate patients with chronic diseases to adhere to the prescribed management by healthcare provider. Now this competency in pharmacology relates to 5.1 competency and 5.4 competency. 5.1 is communication with the patient with empathy and ethics, and 5.4 is explain to the patient the relationship between cost and compliance. Now, since motivation is a type of specialized communication given by counselor, I will discuss motivation as a. Now, this presentation is in three parts. Part A will be understanding adherence and factors which are related to the non-adherence, and include explanation of the terminologies which will be used. Adherence, WHO defines adherence as the extent to which a person's behavior, that is taking medicines, following a diet, and or executing lifestyle changes, corresponds with agreed recommendations from a healthcare provider. Now what is important is agreed recommendation. That means discussion has already been done and patient as well as caretaker agrees that these are the guidelines and the instructions which patient shall follow, and patient agrees to follow. Motivation is defined as the state of activation in response to a need, this requiring fulfillment such as improving quality of life or securing a benefit, generally in the form of encouragement. The benefit here is adherence leads to improved quality of life because treatment is taken regularly. Now, motivation includes need and desire to learn and understanding to adhere to get well. So it is a catalyst for therapeutic change, and the therapeutic change is adherence. To motivate means to inspire, to encourage, to stay in the treatment regime by own internal desire. And here is the role of the healthcare provider. Caring with sharing. When this concept is used, it promotes motivation. Therefore, empathy and effective communication are the integral components and form the scaffold for motivation. Now, dimensions of adherence are described as patient-related, physician-related or treatment-related, and healthcare system-related. But one should remember that medication adherence is not a responsibility of patient alone. It is a teamwork among the healthcare providers and the patient himself along with his family. Patient-related factors are that patients do not know the proper knowledge about medicine, inadequate medical literacy. It leads to poor understanding of doctor's instruction. Patients' health beliefs and attitudes towards a particular treatment from allopathy, homeopathy or Ayurveda. Lack of motivation, intercurrent illness, for example, forgetfulness after head injury or physical inability due to fracture. It also leads to poor adherence. Financial dependence is very important. If person is independent financially, his adherence is likely to be more. Individual perceptions of the ADRs, non-adherence after experiencing adverse effects is quite common. And prioritization. Some of the daily activities may be prioritized vis-a-vis drug intake. For example, need to attend duty in time, funeral, solving mess problems, late hour duties, and like many others. Now this may result in preoccupation and forgetfulness. Doctor-related factors are again many: polytherapy, complex regimes, use of single ingredient medicines, number goes on increasing. Ineffective communication, time constraints is a main factor for empathic communication, not considering financial status and cost burden on the patient, and failing to obtain personal history, for example, habits, herbal use, alcohol use, use of home medicines, and conflict of interest. Some may have preference for branded medicine. Healthcare system related factors also are determinants of the adherence. Poor coordination among the ancillary services, caregivers and consultants, access to healthcare facility, rural setting, availability of doctors, transportations, long waiting hours, overburdened caregivers, and availability of medicines in time. Now it has been found that as the number of medicines in a prescription increase, adherence is reduced. With two medicine a day, 70% adherence is found, but when medicine number is 4 times a day, then adherence is only 50%. And when it is 10 medicines per prescription in a day, then adherence only 20%. So number of medicine must be. Number of doses per day also determine adherence, and it has been found that as the number of doses increases from 4 onwards, the compliance or adherence is reduced around 50% from 80%. Non-adherence to medication is overall is around 50% in chronic diseases in developed and developing countries. In one European study on antihypertensives, it was found that 40% patients discontinue medicine after 1 year of continuation. Now, some medicine related factors also determine adherence. For example, use of beta blockers and diuretics in the treatment of hypertension show poor adherence versus the medicines which act through renin-angiotensin system. Therefore, we can say non-adherence can be because of several reasons. Erratic non-adherence is because of the busy lifestyle which I discussed earlier. Unwitting non-adherence is because of the poor medication literacy. Intelligent non-adherence is because it is a deliberate. Once bronchospasm goes, a patient with asthma may stop taking inhaled corticosteroids. And rational non-adherence is when some adverse effects occur with one of the medications, for example, cough with ACE inhibitors or pain abdomen with NSAID use, patient will stop taking it. So overall, barriers to adherence can be clubbed into low motivation, communication barrier, and socio-economic barrier. Now part B is measurement of medication adherence. And some questions a physician can ask can reveal actually patient ability to adhere to treatment. And if it's not adherent, reasons can be found out. For example, do you find any difficulty in taking prescribed medicine regularly? Patient will express what was the difficulty or not difficulty. Of the medications prescribed to you, which ones are you able to take? Patient will answer. How often do you miss taking medicines? He may divulge some useful information. Have you ever stopped any of the medication for some reason? He will say yes, often, sometimes I do. Often, do you not take first, second or third medicine? That means if there are 3 medicine, we must ask for first, second, third medicine individually. And similarly, we'll also ask what was the last time patient took first, second or third medication. We will know what were the antecedents and reasons. Have you noticed any unpleasant effects from your medication? That could be the reason for non-adherence. Have you ever shared medicines with others? That could be the reason for non-availability of medicine. How are these medicines helping you? He will tell whether it is helping or not. Therefore, he is not ready to take them because there is no change in improvement. Now, generally, adherence can be measured by directly observed treatment as was done in DOTS for tuberculosis. Expected clinical improvement. For example, if BP is controlled with medication, it is assumed that patient is adhering. Then sometimes biochemical parameters may also tell. There is a blood test. For example, blood sugar test may tell us that patient is taking anti-diabetic drugs. Pill count is the most important. Patient brings the empty blisters for refill or subsequent visits, and that may tell he has taken actually the required number of medicines as prescribed. Electronic monitoring is increasingly being used, and currently a sensor embedded pill is being developed, which when taken by the patient, it sends a signal to a receiver system around, and that receiver records the exact time of the drug. One of the adherence self-efficacy scale is called as masses, and device masses has also been uh, constituted and studied, administered to the patient with hypertension and other disorders. The revised masses scale consists of 13 items, and it can easily be evaluated on a 4-point scale. Details can be held from the reference. Measurement of adherence in general is called as medication adherence percentage. That is the number of the tablets or capsule absent in a given time when the patient brings the empty packs. Number of tablets or capsule described. Now normally it should be more than 80%. That means patient should have consumed more than 80% of prescribed medicine. However, this ratio or percentage assumes that the things, capsules or tablets which are missing are taken by the patients. Again, in practice, it may not actually be taken by a patient also. One factor which determines adherence is white coat adherence, just as white coat hypertension. Improves medication taking behavior in the 5 days before and 5 days after a healthcare encounter. When someone has to come for next visit, 5 days before he will start taking regularly, with the fear that my blood pressure may be recorded high there. Now, one interesting adherence monitoring system is being used in tuberculosis management in India. It is called as 99 dots. Now this is an efficient electronic system. It is a low cost mobile phone based technology that enables real time remote monitoring of daily intake of anti-tubercular drugs. It is based on a missed call. That is a mobile number is generated on which a missed call is given, and that ensures active compliance. And there is also smart pill box that I'll be discussing. Now, currently this is being found to be useful in patients suffering from mixed infection, HIV and TB. Patient medication is packed in this 99 dots in secondary envelopes which have dosage instructions and series of hidden numbers behind pill. Each time a patient takes a dose of medication, an hidden number is revealed which is unpredictable to the patient. The first part of the number is on the envelope. Patient completes the mobile number and makes a free call or blank call to that number, and thus ensuring the real-time intake of medication, because that call is received at a system which records the time of administration of drug by patient. And since patient's mobile number is already registered during registration for ATT therapy, it is easy to track also. There is a big repository of phone numbers, and thus patient cannot predict any phone number to make a call otherwise that he or she has taken, unless he opens and takes. Only then, once he opens, he has to take it. That means actual intake time is recorded in a real time situation. Now this mechanism also has intelligent reminders for patients. If he is missing, there is a call, and also the system providers, supervisors are also alerted to trace the patient and advise regular intake. Alerts are also sent to healthcare doctors and nurses, and data analytics are also available for supervisors to find out success and failure. This is how a technology can encourage and enhance adherence. The number is generated, made, and the system works when the tablet is opened and taken. Improving adherence, clinically related interventions by doctors. Cost containment is very important, limiting the number of medicines, avoiding non-essential medicines, and generic prescribing. Simplifying treatment regime so that patient is not involved whole day in counting the tablets and taking it. Instead, as far as possible for chronic disorders, medicines which are available as fixed dose combinations as in tuberculosis, diabetes and hypertension should be prescribed. It has been found that 26% decrease in the risk of non-adherence associated with fixed dose combination. Therefore, they can help in enhancing adherence. And use of long-acting or SR formulation can be very easy to be taken once a day instead of 2 or 3 times doses otherwise. It has been time and again shown that generic prescribing is very effective because it reduces the cost burden on the patient. And it has been shown that whenever generics are prescribed, out-of-pocket expenditure reduces and patient improves taking medicine. Therefore, medication possession ratio also increases. Now, caregivers factors, professional approach, active engagement, showing enthusiasm, an active listener, that is very important, clear, concise, firm statement based on evidence. When they are uttered, then patients are convinced that medicines will make some change and I should take it. Consider cultural beliefs and attitudes. Sometimes people feel that English medicines are not curative. We have to give them evidence that it may not be really true concept of thinking. Do not be directive, but help them to explore and resolve ambivalence. When they are uncertain, they should be convinced that this uncertainty may lead to problem and you should positively take the medicine. Be explorative and resolve the issues which hinder the motivation by using reinforcement, that is giving feedback on the good outcome. Once for a next visit when patient comes, show him that you are adhered and your blood pressure and sugar and everything biochemical parameters seem to be all right. Your lipid levels, your cholesterol levels are also low. Therefore, you should continue adherence and regular medicine intake. Subdue failures because that will also cause demotivation initially. Now, electronic reminders, telephone follow-ups, they are also important for those who are not able to remember much taking medicine for a long time, particularly with cognitive impairment. Adequate supply and refill, patients' education, I already said, increasing health literacy by giving patient opportunity to read literature, interpret the medication label and understand the therapy. Using pictorials and images for illiterate patients can also be helpful. And finally, empowering patients for self-monitoring. Increase access to healthcare information and disease. Therefore, it will benefit a lot, not only in maintaining diary, but also in adhering to therapy. Now, system-related efforts can also be made. For example, in patients and in hospitals which are accredited, medication reconciliation is done to ensure that patients are not taking duplicate medications, excessive medication, and to ensure that availability of essential medicines is there and they are supplied to patients. Now, part C of this is the presentation is motivation, how a student can motivate the patient. Motivation process based on information, motivation, behavior, skill model. It is assumed that information and motivation develops behavioral skills and behavioral skills enable patient to a change, and here change is enhanced adherence. The techniques which have been used in literature are motivation interviewing is a specialized counseling method which is designed to help patient identify and overcome reasons for their reluctance to change behavior, that is from behavior changes from non-adherence to adherence. Mint links patients' personal values and goals to their health behaviors, thus motivation and confidence for change, and brings about a commitment from patients to change. Now, masses I already discussed can also be a feedback to the patient because it measures self efficacy to adherence. Now, when we are motivating patients, a communication is made, and during this communication, patients' long-term goals, short-term goals are to be linked to adherence so that he can realize how important it is. For example, a patient may have to construct a house in 3 years. Obviously, he should be alright, only then he should be able to construct, and these points should be discussed. If diabetes is not controlled, he is more sick, he will not be able to arrangement, material and events. Adjust treatment schedule with daily routine of the patient and lifestyle. For example, if an antibiotic is to be taken before lunch, it should be around lunch box at office. So it is easier for him to take. Morning doses should be on dining table around breakfast so that patient can take. Explain disease process, details about medicine and benefits of regular treatment by giving evidence. For example, in simple vernacular, one can give, if you continue, your risk of kidney disease will be reduced by this percent. Use analogies and metaphors, a sound mind and sound body. Give examples of celebrities and relatives who have benefited from being adherent to treatment. And of course, inquire about difficulties, if any, during next visit. Now, method of motivation. Here the main issue is to enhance degree of pleasure and meaning a patient finds in continuing therapy. That is active engagement and encouragement. Now the method will be using 3 points: empathic listening, eliciting self-motivating statements. When was he better and why was he better? He has to relate it with medication adherence, and responding to resistance, ambivalence, includes positive. Now here I will show a demonstrative role play which students can do, and we can also tutor them. Mr. Roy, 57 years of age, suffered from diabetes mellitus, hypertension and kidney disease. These are common chronic disorders, and his prescription includes the long-acting insulin 24 units to be taken at night, teneligliptin 20 mg at lunch, glimepiride 2 mg once a day at breakfast, and cilnidipine 10 mg around 11 am, and telmisartan 40 mg along with cilnidipine. Now he is taking tablets as well as injection for multiple disorders. He was fairly well controlled with control of hypertension, blood pressure and hemoglobin A1C, but since last 10 months medication diary shows that he has not been able to take insulin injection regularly or oral medications regularly. He is also absenting from duty with feeling unwell and having headaches. He feels depressed and disinclined to take medicine. His wife is worried and approaches you for consultation. He has not refilled his prescription last month. Psychiatric consultation excludes endogenous. So now, what the role as a student or IMG you will play? Now, this is a dialogue between patient and doctor, IMG. Patient, good morning, sir. IMG, Mr. Roy, you are acclaimed master instructor in career counseling. That seems to be quite a challenging job. So it is engagement. Patient, counseling is time-consuming job and I hardly get time for my domestic course. I am worried because I have to build house in next 3 years before my retirement. And now is a time when he should be concerned about disease as well. So IMG asks, and what about your disease? I am having high blood pressure, diabetes, and now my kidney is affected. I have been on medicines, but I feel these are not working. MG, what do you feel is going to happen if you do not take medicines regularly? Don't you think medicines prevent progression of disease? And that is a fact. So that is true, doctor. But so many tablets a day apart from injection, IMG reinforces. Medicines have proven track record for saving kidney, heart, brain, eyes from damage due to hypertension and diabetes mellitus, which is uncontrolled. You know Madam X, a celebrity, she is 97 years old and lived with diabetes in full control. I understand the difficulty of taking many medicines. I can combine medicines so that total number of tablets will be reduced per day. But before that, don't you think and must continue to take medicines regularly? If you control your diabetes and hypertension, you will be as healthy as a normal person. Don't you think it will help you to achieve your life goals? Now, these are the linking methods of the life goals with the. Sorry, sir, I could not think about that aspect actually. IMG. Do you know any of your friend or neighbor who unfortunately died at young age with diabetes or hypertension? Yes, a few of my known have died so. IMG. Have you ever thought why did it happen with them? Patient, now I understand. Because they thought medicines were not worthy and actually stopped injection insulin with false hope of cure by nature. IMG. So, what do you think is the right approach now? So, here is breaking ambivalence. Patient taking medicines regularly to do away with disability. IMG. Sir, even my uncle has diabetes since 40 years, but he is very regular in diet and medication. So IMG says, if other can do, why can't we? Yes, I can. Now here is a reward. Yes, you will. Please collect patient guide to medication adherence from the counter. Take time to read and follow it. There is also one-page questionnaire to be filled in about self-adherence. Please fill it and bring at the time of next consultation. Continue tablets, continue injection, and I shall inquire about your well-being from time to time. Patient, so nice of you. Thank you. Now this is how patient can be motivated by giving time and active listening and giving empathic communication based on evidence. Therefore, motivation is an important factor and doctor can play, IMG can play a very important role. Motivation is internal factors related to the patient but environmental factors which influence the motivation. Some useful references are there and I hope that this discussion will enable us all to deliver this competency in effective way. Thank you very much.